What we're going to move into now is the second plenary, and this is the title of this is Threatened Airway Challenges from Roadside to Extubation. And so what we're playing in here is the area of threatened airways and why they give us the stress and concern that they do. Before we start, it's worth just getting clear what we're talking about with a threatened airway. And these are patients that present with airway pathology that's causing actual or potential obstruction, i.e. there's an element of time pressure here. We don't often know how much that time pressure is. So these are the patients that we're talking about. We don't see them very often. And fortunately for us, it's largely an evidence-free zone, so we can kind of make shit up now. So that's where we're at. The vehicle for this session is a patient journey, following a single case from pre-hospital care through to the moment that we think about, definitive surgical action and then extubation afterwards. The structure of the session is I'm going to sort of take the patient story and throw to the various experts or clinicians who deal with these cases in the audience. Think Insight or something like that style. Although I did joke that I watched a few Phil Donahue back episodes to get in the mood for this session. So to start the session, I'm just going to see there's a free coffee for anyone who can tell me who this person up on the screen is. I know it's a fairly esoteric start to the session, but anyone? No. Close, but no. This person is in fact, This person is in fact Isadora Duncan, and we're dealing with a case of Isadora Duncan syndrome. Another free coffee for anyone who can tell me what Isadora Duncan syndrome is. Yeah, all the coffees are free. So Isadora Duncan was known as the mother or the founder of sort of modern dance, but she came to an untimely death when her scarf was caught in the axle of her car back in the 1920s or 30s. Hence, she has the coin long scarf syndrome, or Isadora Duncan syndrome has been coined because of several subsequent injuries. So we start our journey on the night of the NRL Grand Final, where impossible happens, okay? So we're going to, spoiler alert, save a life in this situation. So it's the night of the NRL Grand Final. 64-year-old guy has been mucking around with his fans doing celebratory burnouts in the car park. He's managed to get his scarf caught in the axle of one of his mates' cars as he was talking to them. And unfortunately, one of them has rung the dispatcher to let them know he's conscious and talking. He's a bit short of breath, his breathing's a bit noisy, and he's complaining of pain in the front of his neck. So before we get into too much detail of this actual case, I want to cross to Robin Papp, who's a paramedic and an academic at the University of Western Sydney and who's worked in both the Sydney and the South African pre-hospital field. Most of our audience probably don't know what the sort of capacity and operating procedures of New South Wales Ambulance are. So run us through who would likely attend this and what their capabilities might be. So,
just a correction, I haven't worked in Sydney. I've worked in South Africa and I've worked in the Middle East, in Qatar. But I have lived in Sydney for a while, and at Western Sydney, where we teach undergraduate paramedic programs, most of our casual staff is from New South Wales Ambulance. So I am familiar sort of with the system and the service. I guess when we're talking about the threatened airway, anatomically and physiologically, the threatened airway is not going to be much different in the pre-hospital setting compared to the in-hospital setting. But there are some, unique challenges that the pre-hospital setting presents, which, especially for those who don't work in the pre-hospital setting in this room, might be interesting. So, a couple of things is obviously the scope of practice, as Adam mentioned already. So to this particular case, depending on what information is conveyed to the control center, they would certainly dispatch an ambulance with ambulance paramedics, and there might also be higher qualified paramedics on that ambulance, in other words, intensive care paramedics. and I can explain the different scopes of practice a bit more. And depending, once again, on the information that is conveyed to the control center, that might also dispatch the pre-hospital and retrieval physicians to that particular case, which obviously brings a different scope of practice and resources to the scene. So scope of practice and experience of the pre-hospital providers is obviously quite important. The environment becomes really important, and that can present a lot of challenges for us. Think of noise, think of, if it's already dark, lighting, crowd control, those sort of things. The other thing that's really important for us to consider is transport times and where this patient should go. And that links in a little bit with the scope of practice of the crew that is on scene. So ambulance paramedics can provide basic airway interventions, OP airways, nasopharyngeal airways, BVM ventilation, and they can also insert supraglottic devices, which, depending on how the patient presents, is probably not the best route to go in this particular case. So they would then make a decision whether they should transport to the nearest emergency department where more advanced airway interventions can be provided, or possibly rendezvous with someone who can provide more advanced pre-hospital airway interventions in that environment, and then transport to more definitive care. Lastly, the mode of transport becomes quite important. This being in Sydney, it would probably occur in a road ambulance, and that in itself is a challenging environment. And if you're interested in exploring that, there's a workshop this afternoon. Or alternatively, if it was a bit more out of Sydney, then the patient might be transported by air. And of course, that mode of transport would influence a lot of the airway decisions on scene as well, because you can't just stop a helicopter and get out to intervene. So the patient needs to be quite prepared and packaged and stable for that mode of transport. So those are some of the considerations. I think
No, that's great, Robin. I think what you've touched upon there is a theme that's going to become really prominent through this discussion, which is, and it's particularly pertinent for anaesthetists where external or extrinsic environmental factors don't usually play a big role in our decision making, and you're saying it's a very prominent part of the decision making in the pre-hospital environment. And I think we'll hear more about that afterwards. You've touched upon the different capabilities of the road services. So although this hypothetical case is in a metropolitan area, let's imagine for a moment this is presented to a regional location, and our rural generalist has called for a retrieval to bring him back to the city. I want to bring Chris, who we've just heard from our last session, Chris McLenachin. You already know who he is, but just to tell us what the capability... Oh, there you go. Perfect. Okay. Just to hear what the different capabilities, so what you guys would be capable of and what would influence your decision to intubate or not intubate prior to heading off to wherever your final destination is.
Yeah, sure. So I'll focus on this patient already being in the district general as opposed to us going to the pre-hospital format, because obviously there are differences for those. But if we were seeing this patient in a district general, the major things to decide is pathology. So what do we actually think is causing what actual injuries do we think the patient's had, often eased by having had some imaging if they've had it there. What do we think is the timeline of the pathology? So is this patient slowly improving? Is this patient rapidly getting worse? And as Robin touched on, what's the mode of transport? Because once you're in the helicopter and the patient's loaded, you're going to have to land a helicopter if you then want to provide a definitive airway. We carry emergency airway bags, which are basically supraglottic devices in the helicopter, but it would be a very bad day to be intubating to be trying to secure a difficult airway that's not going to respond to supraglottic interventions in a moving helicopter. What do we carry in terms of what equipment we take with us? So we're actually very well resourced and very well funded. So all intubations are done on a pocket CMAC, and we have a standard operating policy. Part of the reason we use pocket CMACs is we generally go for DL for skill maintenance, but we have the VL backup. and we also record all our intubations. So we video record all our intubations so that we can review them from a governance process. How would this patient be looked after? Well, the other options. So apart from standard DL and VL on the pocket CMAC, we also carry a advanced airway bag. In the advanced airway bag, we have a D-blade, a video D-blade, and we also carry ambuscopes. So we carry normal scopes and we carry slim scopes as well. So the options here would be, well, what if the pathology is really that you don't need to intubate this patient because we feel that they're getting better and improved, they've had some imaging that looks like it's not going to cause threatened airway, then so be it. But probably from the mechanism, from what we've heard from the difficulties, this patient's probably someone that would be getting intubated. There would be a discussion as to what the best way to intubate them is, whether or not we're going to do standard VL or whether or not we've got time to do an awake fiber optic. We all, despite our background training, emergency ICU or anesthetics, we all do 2 monthly airway currencies, which means every 2 months we go and we practice our awake fiber optic drills. And so we feel very comfortable with our awake fiber optic intubations as well. So it'd really be a decision as to the progression of this patient, whether or not we feel it's in their benefits, then they need an intubation. But then the decision as to the mode of intubation would be based on, again, pathology. And we also, always have friends on the phone. So once you're a staff specialist with Sydney HEMS, you sit on a roster of duty retrieval consultant, which means you sit on a phone, or you sit on base and you have the phone so that one of your colleagues can say, hey, I've just got this case. I could just do with a second brain just to talk it through so we can think about what the best progression for this is. And I think the key decision makers for this is, as we said, progression of pathology. We're very much part of a trauma network. So our goal is not to just get the patient to the hospital, or whichever hospital we're going to. Our goal is to get the patient to the hospital to get the interventions they need and get them rehabbed and back home. So if we think that this patient pathology is progressing and we think that it would be better and easier for us to look after this patient and intubate them rather than drop them with a worsening airway at the hospital, then we're very much part of that network and we want to contribute to patient care.
Perfect, thank you. And I think just want to focus on that's the second theme, that it's no presence or absence of a single symptom that are the indicators. It's the really key here is the progression and how rapidly it's going to progress. So there's the external environmental factors that will drive it and how quickly the disease is progressing. Okay, I want to switch to Max Outred now. Max is a P1 paramedic, and this case has happened in northwest Sydney, and Max works out of Northmead, so he gets the call from the dispatch. Max, first, just let us know what does a P1 paramedic mean?
P1, me at the moment, I'm a P1, so you've completed a year of P1T as a trainee from uni new grad, and then you're starting a paramedic, do a year of supervised, and then you're fully qualified. So I'm that stage now in my journey.
Mm-hmm. Excellent. So you get the call, you arrive on scene. This is our gentleman. You can see the clear marks and bruising around the spine. You feel you can't exclude a C-spine injury based on what you know. Here's a sort of an A to D assessment. He's not particularly unstable, talking in full sentences. He has got a bit of inspiratory stridor. Most other signs, symptoms and examination are normal. He's orientated, he's alert. Importantly, he hasn't deteriorated since the incident. And his only meds are a Pixaban and a statin. He was leaning into the window of a car immediately prior to the burnouts and then got dragged about 20 metres with no loss of consciousness. So basically, what are your concerns based on the nature of this injury and what you know so far?
Yeah, I'm concerned obviously about the nature, the traumatic injury. I can see quite a bit of sort of soft tissue damage, probably some underlying vascular damage. I mean, he's on thinners as well. That's an airway that's threatened, at risk of imminent obstruction through swelling. He already has stridor, so there's already some airway narrowing. Concerned about his C-spine, so I would immobilise this patient. manual inline stabilization. I'd put a collar on him, get him onto my ambulance stretcher, perform a head-to-toe assessment. In terms of airway, as a P1 paramedic, we can't intubate. So I'd be calling for urgent care, urgent backup for intensive care paramedic. In terms of what we can offer pre-hospitally in my scope, IV analgesia, immobilization, supplemental oxygen and continuous monitoring. There's not much else I could really offer this patient pre-hospitally.
Yep. And based on your experience, what are the factors, P1, the MICA guys arrive, what are the factors that are going to, in this case here, how are they going to decide whether to scoop and run or manage on scene?
Yeah, so transport time to hospital is a big factor, how close we are to a trauma centre. Whether or not we can activate aeromedical retrieval, RSI capable. It wouldn't be safe to stay and play. We'd always try to load and go this patient if it's quicker than waiting for aeromedical. They can also rendezvous, as Robin said, and meet us en route to hospital. So that's always an option as well.
So what I'm hearing is 11 o'clock at night, bunch of inebriated NRL fans on scene, 16 minutes, lights and sirens to roll North Shore. You'd be tempted to scoop and run in this situation.
Sure. Definitely. Yeah.
All right. Well, thank you. Anything else you wanted to add about this?
That's all. Cheers.
Fantastic. Thank you. That's really brought us to the end of our pre-hospital phase. I just wanted to, where are we? Just to summarise the key points we've had there, which is that you're going to have a range of capabilities of the likely responders in the pre-hospital phase based on the equipment they carry, their scope of practice, and the type of training that they've had. The decision making will be as much about, if not more about, the environmental or external extrinsic factors and about the course of the injuries going. And often it's how the time it's going to take to get to that destination that's going to drive the decision making. So there's no hard and fast rules that these injuries always get managed, these injuries don't. It's a much more complex set of decision making. So did anyone have any questions they wanted to ask any of our pre-hospital guys at this point? All right, there'll be another opportunity. Okay, there is a question up here. Collars, yeah, I was going to say it's, we might have different management in Queensland and other jurisdictions than we do here in New South Wales. So, Chris, do you want to speak to that?
Yes, soft collars, not hard collars for this awake patient would be my preference. They depends on which part of Sydney you're working in pre-hospitally. And I think that the main decision with this patient is if you put this patient off to, this is going to, I should be careful with my wording here. So we're going to want to do, how we're going to manage this patient. So if we came to this patient pre-hospitally, we would collar on, soft collar. When we put them off to sleep, we do manual inline stabilization. If we entered a point where they were becoming hypoxic and we were unable to secure their airway, we'd prioritize their airway, obviously, over their C-spine injury, save a life before the C-spine. But obviously, ideally, want to be both. Once they're asleep, soft collar, hard collar, as long as it gets changed to an appropriate collar at their destination.
What's that, sorry? Right. Oh, we do. He's been drinking all night, so I think we know the answer to that question. Okay, so we're moving to the hospital phase now. Toby Fogg, who is a FACEM, I think he's up there. He's a FACEM, also a pre-hospital care doctor, and with a particular interest in airway. You're the admitting officer this night. You get the BAT call with this information. What are you worried about? And with blunt neck trauma, and how do you prepare for this?
Blunt neck trauma, lots of red flags here, particularly in this guy. But you're worried for injuries to the aerodigestive tract. You're worried about injuries to the vascular structures, and this guy's on a Pixaban. You're worried about bony cervical spine injuries. You're worried about injuries elsewhere. So you got a head injury, thoracic or abdominal or pelvic injuries as well. He's 60-something. He's in that more vulnerable age for trauma. It's 11:30 at night by the time he gets here, so time is a factor. It's great to work somewhere like North Shore, but at this time of day, people are starting to leave. I'm somewhat comforted by his sort of progressive stability, but that's not going to last forever. And so I need to start preparing before he gets there. I've got 10 minutes or so. So beyond the normal trauma team, clearly there'll be a call put through to ENT and anaesthetics, and a phone call to anaesthetics to describe the situation that we may find ourselves in.
Fantastic. All right. Well, that was my next question, is who you want there. So as part of your assessment, the neck felt a little bit crunchy, and you do an X-ray and you can see extensive subcutaneous emphysema on the X-ray. How does this change things?
I suppose, does it change or does it confirm my concerns? Like that there is an injury to the airway at some point. It's unclear at this point where that is. I'm hoping that everything else has remained stable, and we need to formulate a plan. Do we go to imaging now, or trajectory-wise, should we be thinking of managing his airway before taking him to imaging, noting if his stridor's worsening, he's got a belly full of beer and bourbon.
You're referring specifically to the donut of death here?
Yes.
Yeah. Okay. Yeah, and that's obviously a real dilemma, isn't it? And this guy, I imagine, is sort of, without eyeballing him, he's kind of sitting on the cusp of, it would be a little bit of a white knuckle ride on the way to CT. Is there any holding measures or time buying measures that you could or would implement here? Steroids, high flow, BiPAP, anything like that?
Steroids probably won't help me in the next 20, 30 minutes. I'd be concerned about positive pressure ventilation. Maybe high flow at relatively low flow rates may improve his oxygenation, but there's a balance to be had there, of course. You don't want to worsen that subcutaneous emphysema. Maybe keep his mouth open. So then who are you making feel better?
Fair enough. Thank you, Toby. So as you, Matt, you're the fellow on. So Matt James is a provisional fellow in anaesthesia. He's the senior most anaesthetist in the hospital at these times at night. He's also doing an airway fellowship this year. He gets the call from Toby. From what you've heard of this patient, does he need immediate airway management?
I mean, all of those, that history of the signs and symptoms are concerning, but right this second doesn't need a rapid sequence induction or a crash induction, no. But certainly based on that, I think the patient will probably require an intubation, if not for just the airway securement itself, but also potentially for a neck exploration with the ENT team.
Okay. And so if it doesn't need immediate intubation, where would you be thinking, where do you want to go to manage the airway?
So any anticipated difficult airway, I 100% want to be in theatres every single time, unless the situation dictates that I need to intervene earlier.
Yep. So let's say you have got time, but theatre say, no, we've got a Whipple's overrunning, the heart's overrunning and a Caesar's just been called. You can have a theatre, but it's in about an hour and a half. What can you do? You've got time, but you haven't got the location that you want to go to.
Okay, so it sounds like we are going to stay in resus for a while. I think that's a really good environment for the patient to be in whilst we're sort of buying time for theatres. Things I'm thinking about here for this patient are, going down and obviously examining the patient. So sort of repeating the primary survey, make sure there's nothing that's been missed, for example, a pneumothorax that could be contributing to the physiologically difficult aspect of it. From that point, I'm also thinking about, again, in the history, the progression and the timeline of the injury. So I'm rechecking when the injury happened, what the time is now. And if it's been several hours and the patient hasn't changed clinically, I'm pretty reassured by that we can probably hold for another hour in resus. I'm then thinking about how do I optimize my sort of non-patient factors here in resus to improve the sort of situation that I'm in. So I'm thinking about personnel. So it's an early call to probably a senior consultant anaesthetist. I'm going to be contacting the senior ENT consultant via the phone if they're not already in our resus already. At a minimum, a fellow, I think, should be there for this one. I'm also going to call my anaesthetic registrar, who should be in the building, and to come and assist. And then I'll be also asking for a senior anaesthetic assistant, whether it's a technician or nurse, to come and assist me in ED. We've got great nurses in ED, but when it comes to advanced airway management, I want someone who's really familiar with the equipment that we use. Equipment-wise, I would love to get the difficult airway trolley from theatres down to resus. That'll have a bronch and a video laryngoscope, both hyperangulated and standard geometry. And then lastly, I'd love to get a bit more information about this patient if it's safe to do so. So if we're in a resus, a nasal endoscopy can be really valuable. Patients tend to tolerate them really well with a slim scope, and that gives me a lot of information about any supraglottic pathology. And look, if this patient can lie semi-flat, with a few pillows in the CT scanner, I'm really highly considering that, because from all the literature we've read about blunt neck trauma, it seems like even with those ligature marks and the signs and symptoms they have, it's really hard to correlate the level of injury within the laryngotracheal region with what you see on the front of the neck, unfortunately.
So it sounds like what you're saying, Matt, is that rather than having a binary approach to we manage all of these patients in theatre or we manage them all on the scene, that there's a bunch of both patient factors and external factors that help you decide where you're going to manage it, when you're going to manage it. Is that correct?
Absolutely, yeah.
All right, I'm just going to bring up a slide here, which when I've been thinking about airway trauma in the past, I've actually referred back to this, which isn't specific to the threatened airway. This is helping decision making when we rescue an airway, a difficult airway, and we manage to re-establish alveolar oxygen delivery. Deciding what to do next is driven by both patient and airway factors, but also external factors such as the situation and the team. And I think it's the same set of factors that help us decide when, where, and ultimately how we're going to manage the airway. So I think you don't have to memorize this. This is not something to take notes about, but it's just to really think about, you can't be too dogmatic about things when you don't have the experience or the skill set, or your team doesn't have that experience or skill set. But if you've got time, you can bring that experience and skill set to you. And it doesn't matter what the pathology is. If you're in certain environments or you've got a trajectory that's heading towards complete airway obstruction, you can't have perfect. And perfect is often the enemy is good, I think, is the Voltaire saying. So I think we have to remember that you've just got to make do the best with what you've got at the time. So Matt, you mentioned that you would like experienced help. I want to now go to Kirsten Fraser, who we also met in the previous session, anaesthetic tech and an ex-chair of NZATS or an NZATS. For those that don't know, that's the equivalent of an anaesthetic nurse here in New South Wales. I think RPA also have anaesthetic techs, but they're very specific to anaesthesia. With the threatened airway situations, why is it important that you're called early and even while the patient's still en route to the hospital? What can you do by getting early notification?
It comes down to resources. A, we can bring or find equipment. B, we've got, again, that holistic overview. So you were saying you had a Whipple's overrunning and a cardiac and an obstetric case. Cool, but could we bring the patient to the PACU area so at least they're closer to and we're able to monitor them more closely? Do we need to bring an anaesthetist down? So the anaesthetic tech at my hospital goes to resus for these trauma calls. The anaesthetist doesn't. It's usually an ICU registrar. So I would be thinking, right, I'm going to call whatever consultant is on and make sure they're at least aware. Are they on site? Because depending on the seniority of the fellow or the registrar on overnight, they may be across the road at the hotel. So I would want them in the building. I would want them coming and assessing the patient. I would, again, down in our ED, we don't have scopes. So we've only got video laryngoscopes. So I'd be going upstairs and making sure I could bring down, we've got ambuscopes, so I'd bring those down both sizes. Again, making sure, because our hospital doesn't provide after hours ENT service, making sure that somebody has at least called them, made sure that they can come from another hospital to us. So it's thinking about all of those logistics and the human and technical resources that we can have and where we can be.
Fantastic. And I think we've heard both Matt refer to and you refer to the value of a scope both in assessment into performing a nasendoscopy or as ultimately part of the plan, the primary plan for managing the airway. That does raise an interesting question. If we think that a scope is going to be an important part of managing these threatened airways, which invariably come through our EDs, how many of you here work in an institution that has scope stock standard in their emergency departments? So a smattering. It's interesting. That's a change, I think. I suspect if I'd asked that question 5 years ago, we would have had almost no hands. So I think it is a change in process. Just last question for you, Kirsten. With so many people present, multiple disciplines all coming together in an environment that's unfamiliar for many that are there, what have you seen? What's key to the airway strategy being successfully implemented in these situations?
One thing that I notice, especially when it's quite chaotic with lots of people around, is that the clinicians tend to forget to talk to the patient. We've got a conscious patient who's probably quite concerned that there's a billion people running around, and actually explaining to the patient what's going on, what might need to happen, and reassuring them that all of these people are skilled and there to help them is probably one of the first things I'll do, as well as considering in my head what the actual airway plan would be. But making sure that whoever is going to be managing the airway is experienced, is comfortable with what they're doing. We know we have a plan mapped out of what might be A through D, and keeping a general eye on everything to make sure it's running as smoothly as possible.
And I think that's a really key point. That hands-off oversight is why, when it works well, I think airway management in the ED is a synergy of two really fantastic skill sets. And the skill set of standing back and keeping oversight is not a skill set that anaesthetists hold in spades, whereas ED are absolutely, it's drilled into them. Having a hands-off leader, a coordinator that will very rarely venture past the foot of the bed. And I think once that role allocation is done and they're having that appropriate hands-off leadership is when we really see airway management going well. And I think we could learn a lot from that in how we manage in theatre emergencies, which often evolve de novo, and we really struggle to step from the single operator model to a rest type model where someone comes in and coordinates the situation. At this point, I want to go to Associate Professor David Vivas. He's a head and neck surgeon and he works in a busy trauma hospital. David, you've gone home this day but have received a phone call and a text from your fellow who basically has gone to ED and performed this nasendoscopy.
Just breathing through your nose, well done.
Thank you.
Perfect. Stick your tongue all the way out. Symmetrical, that's the tongue. Say E. Big sniff. So you can see you've got that image frame on his left cord. Big sniff.
Just there.
Yeah, hematoma there.
Yeah.
Big sniff. You can see the right cord's moving, the left cord's not.
So what's being demonstrated there is a big hematoma coming out of the laryngeal ventricle on the left and poor cord mobility as well. So on sniffing, the patient's vocal cord should abduct substantially. That's the promotes abduction in airway. So looking at that, that's very suspicious. Well, it's obvious laryngeal trauma. It's suspicious that there's a fracture in the laryngeal cartilages, just looking at that. And you're only just seeing the upper parts of the larynx, but thyroid cartilage fracture would be
something that you'd be very suspicious about looking at that.
Is that one of the injuries that you see frequently with this type of blunt laryngeal trauma?
Yeah, sure. So as we've mentioned before, the visceral column structures are at big risk. That is the laryngeal cartilages, thyroid cartilage, cricoid cartilage, hyoid bone. But then also considering the vessels and the bony anatomy. The other bony anatomy, that is the spine in this patient. So in terms of the larynx, the commonest thing we see in blunt trauma is probably a less severe injury, usually a football injury of some sort, or someone having a fight, but essentially because the thyroid cartilage is calcified and ossified from fairly early adult life, the commonest injury is a thyroid cartilage or thyroid ossified cartilage fracture, but there are variations and degrees of that. That's probably the commonest thing we see.
Okay, so I want to come back to you afterwards with some specific surgical management of these injuries. But I'm guessing with the information you have at this point, you don't know whether you are going to manage this surgically or not. You don't have enough information.
No, that's correct. And just a comment about nasendoscopy as well. I think in this scenario particularly, we seem to have a little bit of time, and so we've certainly got enough time to do a nasendoscopy in the resus bay. We've got some information because someone's done a chest X-ray, so that gives us more information. In terms of how to manage or even diagnose exactly what's going on, CT scan is very useful information, and ideally what we would have before exploring a neck.
Yep. So at some point he's going to need a CT scan. What we know is highly suspicious of a laryngeal tear. Awake tracheostomy is often a recommended management of these patients to get below the lesion rather than fiddling around above and potentially making these worse. What are the factors? Tell us in reality what it's like doing an awake tracheostomy, and what are the factors that make it more or less likely to be successful?
The urgency of it is one of the biggest factors. So if you have time and a patient who can lie flat, and ideally if you're in an operating theatre, an awake tracheostomy is a fairly straightforward thing to do, as long as the patient, it depends how badly the patient is tugging in terms of cricoid excursion inferiorly, but if we have enough time, we would often, more commonly do that for tumour-related airway compromise. In the trauma setting such as this patient's got swelling in the neck, makes the anatomy difficult to see. So often the most prominent anatomical feature is the thyroid notch, and the surgical emphysema makes it difficult. There could be, because we don't know yet, there could be some bruising or something going on in the left neck in this patient that we're looking at, which could distort the anatomy over to the right. And we also don't know exactly where the air is coming from. If it's coming from a cricotracheal separation, then that's right where you would be wanting to do your tracheostomy. So trying to do a trachea there. I mean, if you explored this neck in a hurry, you would probably just discover that there's an airway there and just use the hole that's already there. But that's a very exploratory thing being done in a hurry. That's basically...
Yep.
Yeah.
Because it sort of, what you're saying confirms my suspicion that it's a little bit of we often see it as a get out of jail free card. ENT surgeons are here, just do the awake trachea. I'm out. You're easy. You can fix this. But there's a lot of factors, including patient compliance, that are going to really determine whether this is a walk in the park, which unlikely, or is going to be sort of tiger country.
If you're in a real hurry, the only thing you might be able to feel is the thyroid cartilage, and then the next thing would be the cricothyroid region, in which case doing a cricothyrostomy is just, that's why it's probably the quickest thing and the advised thing to do if you're in a terrible hurry, because you can palpate the anatomy better. And in this situation, I mean, doing that, well, as you were doing that, you might feel the trachea, if you could, to see if you could feel a hole there. Very tough scenario, yep.
All right, so it's not something to be taken lightly. I'm going to come back to you once we know a little bit more information. At this point, I wanted to bring our invited guest in, but I'm not sure he's actually come online. So I'm going to talk for Peter Groom, unfortunately. So we did invite Peter Groom, who's an anaesthetist from the Aintree University Hospital in Liverpool, to talk here. He was one of the lead authors on this systematic review of airway trauma back in 2019, it was, or 2016, where they did a full literature review and then developed some what they described as mental model maps of how to manage various types of airway trauma. Peter's got a particular investment in the manage of this, in that the Aintree Hospital has the dubious honour of being co-located with a prison, and they see an inordinate number of hangings and attempted hangings, and so they manage these sort of airways more frequently than any of us would really like. So I was going to get Peter just to walk us through. This was one of 3 mental model maps that they came up with around the management of airway trauma, and this one being specific to laryngotracheal trauma, whether it be blunt or penetrating. They tried to just break it into key decision-making points, and I think what I really want to bring your attention to here is that the key decision-making points are around the compliance or cooperation of the patient, and again the trajectory, how time critical it is. And so it touches upon some of the pre-hospital themes we've already heard about. You're not going to get in an ambulance with a patient that's thrashing wildly with a potential deterioration, nor are you going to get in the ambulance when you've got a clear time course that suggests you're not going to make it, or you may not make it to your destination on time. So their approach, which is really quite interesting, is for these time critical patients is to do an RSI, and you think, gee, an RSI in a patient with a known or suspected tracheal tear, high risk procedure. But I'll just let Scott in, even though it's not his. But what they've managed to do is come up with an alternate or a modified technique for RSI, which I think is really innovative. It changed my thoughts on airway trauma, and I've taught it to a number of our fellows here. I was hoping when it was used by one of our fellows last year or the year before, we might be the first to publish this technique, but Peter actually emailed me yesterday with a case report that his registrars did a few years ahead of us, so I've given up on that aspiration now. But what I'll do in a moment is show a video of what this modified RSI technique is, which makes it a really good fallback plan when some of the more safety-orientated approaches, like an awake tracheal intubation under local anaesthetic, might be done, or a more controlled awake tracheostomy. So these are really in that time-critical situation. Interestingly, when I've heard Peter talk about how they manage it, they do most of these procedures in the emergency department. And it is a case that they do stock, as a result of having managed a number of these, the fibroscopes in the emergency department. The other question I had for him is, it's one thing to do the fibre optic assisted RSI in ED, but what about topicalisation? That's something that we've got all the equipment, and my vision of how you're going to trying to topicalise an airway in ED is that you've got someone running backwards and forwards from the operating theatre 3 or 4 times as you forget this and forget that and need another piece of equipment. And what Peter said is, we actually just stock TCI pumps of remifentanil. We use low doses of remifentanil. We use no topicalisation, and they very rarely cough or buck. And I think it's a salient example of what a patient that is fully adrenalised, looking their mortality, looking down the barrel of their mortality, what they will tolerate. And I've seen it a few times that in this extreme situation, patients will let you do a lot of things to their airway, as long as you're gentle and not being a bull at a gate with it. But it's interesting to hear that. I have heard from other fellows that have done fellowships there that occasionally their awake intubations are a bit industrial, but mostly they're getting away with it. Rather than walk you through any more of this, does anyone have any questions, or does this make sense as an approach, with the key decision making being around the time available and the cooperation of the patient? Yeah, Anna.
So just to clarify, in that case, this case you're talking about, you're going to intubate the patient with a fibre optic scope through the tube, and you're fairly confident you'll identify the level of the lesion?
Not in the case we're talking about, because it's not time critical. At the point that we're at, we would be looking to go via the CT scanner to the operating theatres, and my preference would be an awake fibre optic intubation.
And here, it's quite easy to identify the lesion with the scope, presumably, if you do this in these other scenarios?
You don't necessarily have to identify the lesion, you just have to not go through it. So all you need to identify is the lumen of the airway and stay in it.
It's not easy at all to identify. You probably couldn't identify cricotracheal. In fact, you can't identify cricotracheal separation by an awake nasendoscopy, basically.
You just want to make sure you're beyond it.
Yeah.
All right, so this is actually a photo of the cart that Peter has set up. I'll come back to that question in just a second, in their ED. And you can see they've basically jerry-rigged an AMBU monitor, an A-scope monitor and scope to their standard cart. And they've set up their drawers in a very organised way. And again, this is a theme we'll come back to when we hear how ICU have set themselves up to manage unexpected and time-critical airway emergencies. This is their decision-making tool about whether to go to theatre or to manage on site. It sort of gels with their other mental model map, but again, it's really coming down to the key factors. But what isn't included in that is those extrinsic factors. If you're going to apply that to various other hospitals, your decision making around whether you're going to leave the ED to go to the operating theatres in a metropolitan hospital in the middle of the day is quite simple. But if it's a regional hospital where you've got to call your staff in and it's going to be an hour before the operating theatres are ready, it's a very different set of decision making. Similarly, you might be in a hospital where the ED is directly adjacent to the operating theatres and it's going to take you a 100-metre dash, no problem. But if you're going up two lifts and 500 yards of wheeling a patient, you've got to think really, it's a really salient decision about whether is it worth it, really taking that risk, because what am I going to do en route? So the same decision making around staying or going applies in the hospital, as we heard from our pre-hospital guys as well. This is a video that we recorded for our meeting back in 2021, which just demonstrates and talks us through this fibre optic, this fibroscope assisted rapid sequence induction. We may not have been able to publish it first, but we will take credit for naming it the Farsi as opposed to the Vafi. No disrespect meant to our Persian-speaking colleagues in the audience.
Hi, Adam. No, not really a question. It was really, I think, to re-emphasise what yourself and Kirsten's already mentioned, because it's not explicit in those flow charts in terms of, do we stay in the ED or do we go to theatres? Because there is absolutely that other place, i.e. closer to theatres, the PACU area, the PRA holding areas. In our hospital, being a really old hospital, our ED is a pokey little ED, and it is, as you've mentioned, it's 2 floors down through really old lifts that aren't working on the other side of the hospital. And so, even whether it's ENT surgeons or, your senior anaesthetic help coming in, I think we notice our trainees in anaesthesia, certainly when we go to ED, the loudness and everything in ED can actually increase that stress level without you really realising. And also in terms of flow, workflow for the hospital, sometimes just helping our ED department out too by moving that patient to a slightly quieter area. And we've actually also seen it help with our patients reducing their stress levels. So you actually take a patient from being uncooperative to being slightly more cooperative because actually their stress levels are reduced as well. So we've heard our pre-hospital colleagues talking a lot about the environment playing into their decision making, and I think sometimes, certainly when we're busy in our little metropolitan hospital, we don't think about that necessarily in our little spaces within our hospital as well. So just to reiterate, thank you.
Fantastic. Thanks, T. Just before I show this, I want to point out that this would be the technique if there was no time, if it was urgent and we needed to push on. What we've said about this patient is he's relatively stable, but that doesn't remove the necessity to have an urgent plan. Because as Toby's alluded to, he might be stable now, but at some stage he won't be. And we've already got a narrowed airway because they're Strider. It's going to go pear-shaped fast. And it's not the time to come up with a robust crack-on plan when the patient deteriorates. You have to have that plan both formulated and ready to deploy in case. You can't just say, oh yeah, he looks stable at the moment. Don't worry about what we'll do if he deteriorates. You will not manage that well on the fly. All right, so the technique that I'm going to run you through now is the flexible bronch assisted RSI. And this is a technique that we specifically utilize where we've got a suspected or possible disruption of the trachea below the vocal cords. And the difference here is that I don't have the tube loaded on the scope. I'm going to go about a rapid sequence induction as I normally would. And basically at the point that I get the tube to the glottis, I'm now going to stop at that point. I'm not passing the bevel of the tube much beyond the cords or basically at the cords, and I'm going to get Bill to come in and rapidly pass the scope beyond any disruption that might be in the trachea, and that allows us sort of a Seldinger technique for us to safely pass the tube beyond any disruption. At that point we come out. Again, we don't want to ventilate until we've got air in the cuff because that risks making any subcutaneous emphysema worse. So that's the rapid sequence, fibre optic assisted rapid sequence induction. And the main difference between that and what people refer to as a VAFI is the VAFI leads with the scope to try to navigate beyond any upper airway pathology or difficulty. It takes time. It's where you're anticipating difficulty. This is designed for rapid. You've made this patient apneic. They're not going to stay oxygenated for long. You're trying to do this as rapidly as possible. Our patient, potential C-spine injury, you can do the same thing with an introducer in the tube. Just need to take the introducer out and swap to the scope once you've got the bevel through the cords. I'm recognising that we're running out of time. So key points there, I think we absolutely want to recognise that both extrinsic and intrinsic factors are going to drive our decision making. Where we've got evidence of a tear to the tracheal injury, we want to avoid blindly putting devices beyond the vocal cords. If we have to and we don't have a scope available, a small tube has been shown to have a high success rate even in the presence of tracheal tears. So if your hand is forced, an RSI is a good idea. But in the absence of that, awake intubations with a scope-assisted RSI or an awake tracheostomy are all good options for these patients. David, I wanted to come back to you just to talk us through how you would decide, what are the factors that decide whether you're going to operate or not operate. I don't know whether the Schaefer in its original form like this is still used as a classification. It's often referred to in the anaesthetic literature as the decision-making tool. What are the factors that are going to help you decide whether to manage it operatively or not?
Well, firstly, we still talk about this in our literature and in our exams. Basically, the degree of we would operate to explore most commonly for a laryngeal fracture that is displaced, sometimes for arytenoid dislocations if we diagnose them. And certainly the higher grade injuries there, obviously a complete laryngotracheal separation needs surgery for repair. But in the lesser injuries, it's a little bit of a judgment based on CT degree of displacement of the thyroid cartilages, and a bit of it depends on what the patient's voice is like. So it's all there's a degree of injury. So quite a few of our patients don't get intubated, but might have a laryngeal, might be observed for a bit, and we'd do a CT. We'd look at what their voice is like when it settled down a little bit, and we use degree of displacement and patient's voice to make a decision in the medium side, the medium degree injuries. The real small ones we obviously don't operate on. The mild hematomal laceration without fracture, we would just observe.
So I'll give you some more information in a moment. So this patient unfortunately did deteriorate. Shortly after having a CT scan, carotid hematoma blew up. He became increasingly distressed, short of breath. Fortunately, we'd prepared for a fibre optic assisted rapid sequence induction. We were able to get a bit of footage as the scope was passing the lesion. That gives us a bit more information. Lesions at basically 3 o'clock, between sort of 1 o'clock and 3 o'clock up there.
Thank you.
So a little bit, no obvious cartilage on show, which is, I think, one of the factors that would determine your surgical management. Unfortunately, I've only able to take some slices of the injury there, but it should show a little bit of a thyroid cartilage fracture, if I've got the right. I have faith. There is I think here we can just see a thyroid cartilage fracture. What's that? Is that a hyoid? Okay, all right. Well, something's fractured. Anyway, whatever's fractured is non-displaced. The patient's had endovascular repair of their thyroid. They're intubated. Would you be wanting to immediately manage the airway injury, or do you think
he's still got a tracheal injury?
He has, but it was, as you saw, it was fairly minor. It was just a fairly minor tear, no displaced fractures.
Yeah, the laryngeal injury could be, well, first of all, the tracheal injury I think needs to be closed. And I would explore it, as long as it's something you can get at from the neck on CT. You don't need anyone else to help from our point of view. I'd explore it, put some stitches in it, leave the patient intubated with the cuff beyond the injury for 48 hours. If having to do that, the threshold for actually exploring the larynx fracture might have lowered just because you are operating on the patient. We do see patients who end up with voice trouble with what seems to have been a minor displacement. So sometimes we will operate on them. And if we do
need him extubated and assessed afterwards to make that.
Yes, to make that as a formal. But in the situation, you might have left that alone since it's not displaced.
All right. Well, let's work on the assumption that after the closure of the tracheal injury, we're going to manage conservatively and see what he's like after extubation. He comes to you, John Gatwood, the intensivist on call. Again, John is a senior intensivist here at Royal North Shore with an interest in airway management. You happen to be on take this week, and you've got this patient. How are you going to, in these cases, how do you decide when to extubate?
Right, so obviously we're going to take advice from our ENT colleagues who've done the operation. We're going to look at imaging too, but like you, we're probably going to get things wrong, so we might get the ENT surgeons to look at the imaging with us or for us. When to extubate? Well, obviously we're not going to do it at Sunday night at 11 p.m. We've got, in contrast to some of the other practitioners who've been talking today, especially in the pre-hospital and emergency phases, we've got time. So we don't have to rush to extubate this person. There might be a few things chucked into that time, like there might be other injuries, there might have been other operations that have been needed to be done, and we would leave a patient intubated while they have all of that stuff done. And then we're trying to optimize the patient as much as we can. So our kind of gold standard for a patient like this would be to have them in an upright position as much as we can. So if they are in C-spine precautions, we're trying to get those removed as quickly as we can. That might need imaging, for example, an MRI, especially in this hospital. Our orthospine and neurosurgeons are reluctant to remove spinal precautions without that kind of, and in this case, it's pretty reasonable, I think. It's high risk of a C-spine injury. We use steroids in this population to minimize post-extubation stridor. There's an old study from a long time ago in high-risk patients, 3 doses of IV dexamethasone over the 24 hours prior to extubation, shown to be useful in preventing post-extubation stridor. We run them a bit dry, so we don't want them all boggy and edematous, and if they've got comorbidities like this guy, a bit of heart failure perhaps, we might use diuretics to dry them out and keep them dry. Then we would do a cuff leak test, and I know that we're going to talk about this imperfect test.
I'm not going to show the
skip
minute just because of time.
Sure.
We're not going to, but yeah, tell us your takeaways from cuff leak tests. So
there's a bunch of papers on cuff leak tests. Some people talk about a minimum volume, a bit difference between inspired and expired, tidal volume of 110 mils. I don't use that in my practice. Other people talk about 10% of the tidal volume leaking out. It varies depending on patient lung compliance, so it's difficult. And to be honest, what most of us do is deflate the cuff and listen for a leak. Great if you've got one, not great if you haven't. If you haven't got one, the chances of post-extubation problems are higher. But we have to look at the whole patient and all the other risk factors. We would also use video bronchoscopic upper airway assessment. We might ask ENT to do that, or we might do it ourselves. A bit more difficult in a patient who's recumbent and they're often very spitty, so we need to dry them out with a bit of glycopyrrolate, try and sit them up if we can. And in difficult patients, from that perspective, I often just sedate them and use video laryngoscopy to assess the upper airway and to make sure that swelling's gone away. Where to do it? We almost always do it in ICU, but we do have a very good relationship with our anaesthetic colleagues, and we would get them up. We've got all the equipment in ICU, but sometimes the anaesthetist who's on will prefer to take the patient down to theatres to do either a staged extubation with a staged extubation kit, or more commonly these days an airway exchange catheter placed with some local anaesthesia down in the trachea, and then having the patient spontaneously breathing with that in place.
And that's your setup, isn't it, up in ICU, so that you're well prepared to manage whatever emergencies arise. You've published on the importance of human factors in setting up your airway equipment. I know that's a really, really great publication from back 2019. Okay, just in the interest of time, let's say for this instance we're going to theatres for extubation. Louise, I'm not going to get you to talk about necessarily what was missing from the DAS guidelines, but just talk about how you think about extubation and what is coming in these PUMA guidelines.
Thank you. First thing to say is that this is unpublished, so if you wouldn't mind not posting anything to social media, and if it's hidden on your phone, that's okay. But yeah, so this is coming next year. This is our extubation guideline that is applicable across all settings, whether you're in ED, ICU, or anaesthetics, and it's applicable to all practitioners. It's easy to use. It's binary decision making. You do not need to commit it to memory because it's designed to be used by the clinician at the time that you're trying to decide what to do. So it's not a cognitive aid like the Vortex. It is designed to be used in real time. And you answer a series of questions. The big thing that's unique about this, that's currently not yet in the literature, is a linking of the risk with a strategy. So we're hoping that this will significantly add to the literature on extubation. So I might just sort of run through what I might be thinking in this patient, and that the thing to really stress is that the only answer that matters to each of these questions is what you, as the practitioner, with the patient in front of you, determines to be the answer. You're not able to use this hypothetically, and you can't answer the question about someone else's patient, because you do need to make the decision about ventilation with a supraglottic airway, ventilation with bag mask, etc. So it's a bit artificial to do it hypothetically, but I'll give it a go. So, the first question is, did the initial intubation indicate that reintubation should be rapid and reliable? I think I'd be forced to answer no to that for this patient. So then we follow the red arrow down. Is there a significantly increased risk that the patient will require time-critical reintubation? At the point that they've sat with John in ICU for a few days and everyone has decided that now's the time to extubate that patient, I would probably answer no to that question. So we follow the red arrow along, and we're now in column 2. And now we're asking, is rapid and reliable ventilation with a face mask or supraglottic airway anticipated, and is there a margin of safety? I'm going to presume that for this patient, I've looked at them and I've decided, or we've tested, that bag mask ventilation, actually we haven't tested in this patient, but I've decided based on my assessment that would be that would be possible, and there would be an adequate margin of safety. So I think it's very likely for this patient that I'd end up at awake extubation, and I'd perform that as we've discussed in theatre. However, for a given patient, for a given practitioner with their level of comfort, you could see how you could easily end up at awake extubation over an airway exchange catheter. And almost certainly for this patient, when we were first having these discussions, as David said, we would have ended up at defer extubation, because there was going to be patient team or situation factors that were likely to significantly improve, hence the going to ICU intubated for a few days.
Fantastic, thank you. So where have we ended up? Which little column have we?
I think we'd almost certainly for this patient end up at awake extubation.
Okay, all right. And would you use an airway exchange catheter in this situation?
I'd use an airway exchange catheter if I'd landed on airway exchange catheter.
Mm-hmm. So which one? You're saying you've landed here? Yeah. So you're not worried about this sewn up tracheal tear necessarily getting caught in an emergent reintubation?
I guess the decision making is, am I going to need to, is this patient at a risk of time critical reintubation?
Okay.
Given that I've answered no to that, if we need to reintubate this patient, we can do it exactly the same way we did it the first time with a fibre optic bronch.
Fantastic. All right. Well, we've gone well over. We're at the end. Key point here is don't confuse the thyroid cartilage with the hyoid cartilage. You've probably got questions for the various experts in the audience, but I'm going to get you to save those for the break. We're going to be coming back at 20 past. I hope this has been a useful presentation. This is our patient 2 months later. He's had a very successful outcome despite a really nasty injury. Back in 20 minutes.